Hello and welcome to Recalibrating with me, Sharee Johnson. Hello, a little celebration today as we launch episode number 20 of Recalibrating with Sharee Johnson. It's been such an exciting, joyful, meaningful ride this year in 2026 to launch our podcast. I'm deeply grateful, feel quite celebratory about the first 18 guests in the first 20 episodes so far. You've heard from really esteemed doctors who have made a big difference in their particular specialties in their area of medicine. You've also heard from a couple of patient advocates who I'm especially grateful for their time. Sue Robbins from Canada and Sharee Deer from Melbourne. The work that they do on behalf of patients and in helping all of us as clinicians remain aware of the patient journey is profound, and I really am deeply privileged to have been able to talk with them, to know them, and to share some of their story on the podcast. I also want to acknowledge Rebecca Clark, the first nurse that we've had on the podcast. I'm definitely looking for more allied health and nursing people to come talk with me here on Recalibrating with Sharee Johnson. If anybody would like to share somebody's amazing work or examples of recalibrating. And I want to particularly acknowledge the researchers as well. We've heard from Dr. Victoria Lister, one of the most popular episodes in the first block, talking about the silencing of junior doctors. We've heard from Brian Lee talking about the impact of the work that people do in healthcare, the frontline work, and also the impact on their families, which I think also is really important research for us to follow and understand. And Duncan Brown investigating how organisations help the frontline workers feel fulfilled or satisfied, or the opposite, wanting to be not helpful because of the frustration that the system causes. I hope that you find this little recap of some of our guests useful. Perhaps it will help you want to go and listen to some of the other episodes in full. We have tried to create a bit of a story here for you to listen to how the ideas are progressing through our conversations. But most of all, I want to remind you of why we have this podcast called Recalibrating, that everybody can recalibrate their lives, that we are in fact all doing it all of the time, and that with the right skills and the right community, we have the opportunity to keep recalibrating in ways that make life feel fulfilling, interesting, useful, and that we can extend that as well to the health system, to bigger organisations. What is it that we need to adjust and adapt a little bit? What are the skills that we need to help us collectively get back in balance so that we can deliver the best work to each other, we can support each other the most effectively, and that we can remain and build communities that are life-enhancing and empowering, that help us imagine and feel joyful about these short lives that we have in the world together. So here's episode 20. Thank you so much to all the listeners for your support so far, and we really look forward to bringing you the next 20 guests in the back end of 2026. May you be well.
I remember the first time I got an email, the acceptance email, I just felt this passing of electricity from top of my head all the way down to my toes. It was just so surreal. It was just sort of this fulfillment, this acceptance that, okay, you made it to the next step now, and you're going to be moving to Sydney and studying medicine. So yeah, it was a very, very huge achievement for me at the time.
And so do you bring that lesson from Lamar with you still, that idea that don't limit myself before I even try?
Yeah, definitely. It reminds me of Cars, the movie, The Lightning
Yes,
McQueen.
yes, yeah.
Yeah, there's a part of it where they said to him, "Oh, like, how did you know that you could do it?" And then he just said, "I don't know. I just didn't think that I couldn't, Like that was the sort of mindset that I think was very similar to what Lamar was trying to imbue at the time, something that I've carried since. Yeah, for sure. When I was in my third year of medical school, I did found Pseudo Australian MD. That came because in so many spaces throughout high school, undergrad, postgrad, I felt like I was invisible, but at the same time, I was very, very visible as an African Australian person in these spaces.
Oh,
It's medicine through the eyes of being an African Australian medical professional is because we oftentimes don't even get the opportunity to tell our stories. And if we don't tell our stories, then who's going to tell it in a way that we actually approve of it? So we have to be the ones to tell our stories and to tell that narrative. And that's what the podcast was all about. Everyone was so tuned in, everyone was so focused and was approving of what people were saying because they could relate to that. They could see themselves in the stories and the experiences that people were talking about. We had more than 20 African Australian medical professionals who were doctors in the room itself. And I've never seen that many African Australian doctors, like let alone two, in the same room. So it was very, very historic.
Recognizing that workplace culture plays a very, very strong role. And like you said, one of it is just that aspect of not that guilt for staff as well. But there's the other aspect that plays into the workplace culture in healthcare is that guilt for patients, right? Because it's not just you letting your teammates down or your team down, but a gap in staffing would mean also drop in quality of care for patients, so that affects that. So that there's a lot of that guilt there as well. And how do we help change that workplace culture? And a lot of it comes down to staffing, and if we got proper staffing, that would help. But the older and the more senior healthcare workers I've talked to, who've managed to kind of manage or kind of address these concerns, they realize that you can't hold this burden, there will always be sick people. There will always be someone who needs help. The emergency room will never be not filled, right? But that's not your job. Your job is just to provide the care, and that's it. You're not here to heal the world, but just to kind of help one at a time. So I think that process of, I'm learning that myself. The work will never go away. People will always need your help. Being able to accept that, take the time for yourself sometimes, and it's okay. I think healthcare system will still work, and they will benefit from a healthier and I think a more regulated healthcare worker rather than overworked healthcare worker who might leave and then leave a gap there as well.
And when we met around COVID, that's what I was really struggling with. I was really struggling with, how do I stay being a doctor, be a mom, but also do things that I really like and enjoy? Because exactly what you said in the introduction, doctors seem to think that this is all I have. I'm a doctor and that's all I do for life. I'm here to treat people and care for people, and that's it. And I was thinking about something else. I'm like, but I have other interests. I like other things. I'm pretty ambitious, and I tend to say yes to a lot of things. Finding this balance where you're thinking to yourself, but what about me? What do I want? And this is where I come back to the system. The system does not, unfortunately, allow people in many healthcare professions to explore those desires, those skills, those ambitions. And I think it's a wasted opportunity. Because you might be at this stage now, or for me, where I'm thinking, well, I have my practice. Within my practice, I want to be more innovative. And I'll give you an example. About 4 months ago, I reached a point where I was like, I understand these signals. My body was giving me signals, and I'm like, okay, I recognize these signals as burnout. And I wasn't sleeping very well. I was extremely frustrated about a lot of things. And I took 2 weeks off, and I just told my manager, I have to take these weeks off. I can't do this anymore. So I went 1 week by myself away, and then the second week, it was around Christmas, where I took my daughter and we went to Portugal. And I remember coming back and I said, okay, Sabine, something has to change. Well, I want to take a moment to thank you, Sharee, because when I reached out to you back then, I was really struggling with where my path and my career was going. And I remember reading your book, and I remember thinking to myself, it's okay to seek help. And I want to reiterate the fact that just because we're doctors, we are humans and we suffer. And a lot of doctors suffer in silence. And I think this is one of the things that, again, the system has done completely wrong by not allowing a space for vulnerability, by not allowing an open space for talking about vulnerability, mistakes, anxiety, frustrations, anger, because we deal with so many emotions from other people and they expect us to just take it all in. Okay, we're the filter, right? I have to take your emotion today because you're just angry because you had to wait 25 minutes before you got to talk to me. I have to take your emotion because you're angry because I didn't prescribe a medication. There's a lot going on, and the system has to change. But sometimes the system isn't ready for that change because it likes the status quo, right? But I want to reiterate that as doctors, please remember that you are humans first. And your body is telling you every day what's wrong and what's right. And your coaching, what you're doing, that recalibration is helping us understand how to connect with those internal signals. And sometimes external signals are also being brought up by people around you. I've had my father say to me, Sabine, are you okay? You know, when I talk to you, you sound really exhausted. Make sure you rest. Your partners are telling you things. Your children, like Kate told me, remember, Mom, you're really negative about work nowadays. Maybe you should think about your mental health. Those signals are real. So what you're doing is amazing. So I really want to highlight that doctors, people, health professions, please, you are human, vulnerable. And I say to my team, I always say to them, I want you to put yourself first before a patient. And I do this on purpose. I say, because if you're not good, you cannot treat a patient.
I think it's that we're really good at sacrificing ourselves for the benefit of others, and not stepping back, because we can push on. Often we can keep pushing, keep pushing, keep pushing. And that's where the self-care part comes into it, being able to step back and appreciate what we do and how we do it and what we have done, and the achievements that we have made. And again, I reflect back on what I said earlier about, you feel very average amongst all the brilliance that is in medicine. It's not often that you step back and acknowledge your own successes, and we're very good at seeing our failures. We're very good at seeing the things that we miss. And so one of the things that I do is help people to step back and see what they are doing that's valuable, and start to appreciate themselves and what they bring to the situation. So that's one of the themes, is that sacrifice for the benefit of others. And I go back to my earlier statement around not at our expense. I've got lots of coaching colleagues now that I value very much, and they're all into helping each other to develop, to grow, to notice what's working, what's not working, and to ask those powerful questions that get us thinking. That's what coaching really is all about. And I've had people around me who've been able to ask those challenging questions. And there's a quote from the book, The Power of Full Engagement, that I think sums everything up. It says, is the life you're living worth what you're giving up to have it? So is the life you're living worth what you're giving up to have it? And I think it is all about prioritization. And I think it's also connecting into ultimately what we feel our purpose is, making sure we're clear on our values and what supports that purpose, and then prioritizing accordingly.
What's important about talking about these issues, not just talking about your ENT specialty and your administration skills and so on, but this human stuff? Why is it important for you personally to keep talking about that in a public way?
I think for me, it's that collision between your work and who you are. It's very hard. People talk about how we are human beings, not human doings, but at the same time, what you do really does matter. And I think, as you've said, you just can't split them. One impacts the other. You need your human doing and to support your human being, and you need who you are as a human being to support what you do. The quest, I think, particularly for clinicians, is we derive joy from, I guess, the deepest joy that I have in work is seeing my patients, get discharged well. When they can return to their daily activities being better, sleeping better, breathing better, hearing better, eating better. ENT is about, senses, right? So if they hear better, see better, sleep better, breathe better, and they are better, that's kind of the deepest joy. It's not, the status or the financial, kind of all of that remuneration and all of that. It's always that kind of human meaning. And that's the thing that is long lasting in my mind. And I think this is also the antidote to, I still don't know how, maybe you can give me the answer. Maybe you have the equation, but the equation in my mind is a lot of clinicians are burnt out. And we're trying to find individual solutions like, mindfulness, yoga, all of that stuff. The system is not causing, but have some association with that. But at the same time, the antidote is actually altruism. Seeing a patient get better is one of the biggest kicks that we get. So in that triad, the system, the clinician, and the patient outcome, I wonder whether, the patient outcome is the antidote to the burnout, changing the system is the antidote. So I don't know. I don't have an answer to that, Sharee. Maybe you have. But for me, I think the reason why I still love talking about the human side of surgery is because that's the thing that will get us going in the long run. Surgical skill, surgical knowledge will keep changing, but it's the human behind the knife that I really care about as well. In my colleagues, in my registrars, in my trainees, I still want to be a voice in that space because that's probably the long-term antidote to the burnout and the mental health effects or negative mental health effects on our work on us. I don't know. Maybe can you piece it all together? What's confused in my mind, Sharee?
We could be here for hours, Eric. The system, clinicians in systems, whether they're in any country in the world, I think I've got a lot to learn about China and some of those countries I have less contact with. But certainly in the UK, in Europe, in America, in Australia, New Zealand, South Africa, a lot of these countries, Singapore, the systems are different in a lot of ways, and the problems are still the same for clinicians. So it's way too simple to say it's the system's fault because even with the variations in the system, we still end up with some of the same problems.
So when we're talking elite professions, it's medicine, law, divinity in the first instance. That was in the Middle Ages when those three came to prominence. Over the years, that's expanded. Divinity has dropped off. So we now have architecture, accounting, law is obviously still a part of that, and other professions that have emerged more recently. But the elite professions in particular behave in certain ways that secure their status, that set the tone, if you like, for what that profession is, carve out spaces. They're social spaces, first and foremost. So they carve out spaces amidst the broader social environment and declare certain things about themselves and that they do certain things and that they have certain knowledge, which is then transferred typically through university education. They also behave in quite aggressive ways. So this sort of boundary setting or carving out of territory can lead to quite interesting stoushes between different professions, each claiming their space, sometimes trying to intrude into the other's space. So we see this a lot in the medical profession with the ongoing debates around cosmetic surgery versus plastic surgery.
Are you finding things that we can work towards to help our junior doctors, given the deep hierarchy and the things you're describing about competitiveness and so on in the medical world? What can we do? What are the things that can help our junior doctors have more voice?
Yeah. The main thing I believe needs to happen is that senior doctors need to lead on these issues because they, at this point, particularly if you go into specialist training, are the other doctors who control outcomes for careers, for the profession itself, the people at the in the upper echelons of hospitals, of medical colleges, etc., often of regulators, universities, the whole bit. There are pockets of what I call pockets of enlightened leadership that kind of came to light on a couple of occasions in my research, but they're far and few between, and they're hard to sustain because they're not happening at the level of the organisation mostly. They're happening at the level of a department or a unit or a hospital. But where they do occur, they're wonderful. And what I believe is happening in those more enlightened environments is that those senior doctors have recognised, at least to some extent, what I call the medical professional game that is being played. So a feature of the game, and I drew on the work of a sociologist called Bourdieu for this notion. He devised the term the game, but it describes the rules that are in place, or the game that is played in occupations or in any social space in which there's jockeying for power and position, which is pretty much all of them. And a feature of the game is that you don't realize you're playing it, or perhaps you willfully misrecognize, and that was his term, misrecognize that you are immersed in a game and that you are in fact playing it. And there are reasons why that occurs. But I suspect that those doctors who recognize what is going on, recognize it as detrimental, are those who can actually do something about it and create environments in which people feel psychologically safe to speak up, which is a term that gets bandied around a fair bit and is a little bit misused, but it refers to the psychological safety to speak up at work, as opposed to other ways of thinking about that. And it's not to say that junior doctors or early career doctors is another term, can't get involved in that kind of activity, but they're often not in a position where they can because of the control that's exercised over their working lives, over their careers, over their job choices, over their training placements, over their exams, by the people who are in fact the same vehicles for silencing them. Because there's a lot of, as many would know, what I call workplace abuses that occur in the junior doctor space, that in tandem with the implicit messages they're receiving from university onwards, if not high school, as you mentioned, onwards, about how to behave and be as a doctor, there are a lot of compelling reasons why they don't speak up, because they can't, which effectively eliminates the notion of choice in silence. I don't know that they are choosing it. A cost-benefit analysis that is conducted by every junior doctor and senior doctors as to whether it's going to speak up or not, whether it's worth taking the risk. So there's a lot of fear. So there's fear-based violence, which is fear of the relational risk, the reputational risk, the career risk, the risk to yourself if you speak up, because speaking up comes with its own set of challenges. You then get potentially, if you make a formal complaint, thrust into the world of having to deal with that. And who wants to deal with that on top of all the challenges of being a junior doctor? There's risk to others. There's a sense that collective forms of voice, say union activity, are not necessarily embraced either, because there's a fear that this is going to impact the patients, because it's often associated with striking, which isn't always the only option available. But I can't do that because I'm going to affect my patients. There's also a lot of futility, so hopelessness. I've seen people speak up, nothing changes. There's uncertainty. I don't know how to speak up. I don't know the mechanisms for speaking up. I'm not good at speaking up. There's, unfortunately, self-sacrifice was another theme. Silence is a strong belief in medicine that silence is evidence of commitment to calling. So if I can soldier on, prove I'm not a troublemaker, I can cop it on the chin. It's can, unfortunately, a badge of honour, but analysis that is conducted by every junior doctor and senior doctors as to whether
it's
going
worth
to
it.
speak up or not, whether it's worth taking the risk.
Mm.
So there's a lot of fear. So there's fear-based violence, which is fear of the relational risk, the reputational risk, the career risk, the risk to yourself if you speak up, because speaking up comes with its own set of challenges. You then get potentially, if you make a formal complaint, thrust into the world of having to deal with that. And who wants to deal with that on top of all the challenges of being a junior doctor? There's risk to others. There's a sense that collective forms of voice, so union activity, are not necessarily embraced either, because there's a fear that this is going to impact the patients, because it's often associated with striking, which isn't always the only option available. But I can't do that because I'm going to affect my patients. There's also a lot of futility, so hopelessness. I've seen people speak up, nothing changes. There's uncertainty. I don't know how to speak up. I don't know the mechanisms for speaking up. I'm not good at speaking up. There's, unfortunately, self-sacrifice was another theme. Silence is a strong belief in medicine that silence is evidence of commitment to calling. So if I can soldier on, prove I'm not a troublemaker, I can cop it on the chin. It's can, unfortunately, a badge of honour.
It's the way the work is structured to allow me to have those relationships. I mean, I've had the experience of working in a practice where I was working very fast and seeing a lot of patients each hour. And yeah, I felt great. And I felt really like I was, meeting a need and servicing a lot of people. But I was like a kid running down a hill, and I couldn't stop. I sort of felt there was a point at which that felt really unsafe. Whereas now, working in the Aboriginal health sector, the model of care is different. There's longer appointments. There's time and space for reflection on what you're doing. There's a lot more collaboration with the people around you in the building day to day. So a lot more conversation. I know that as the white lady doctor, I can't do a lot for some people. I need the help of an Aboriginal health worker or a driver or a social and emotional wellbeing worker. Or, it's so interdependent with other people, and that model of care suits me because my values are about that in life too, are about working together with people and living in a world where we're all interdependent on each other, and we have a responsibility in that system. I found it incredibly lonely and not because I was working with people that didn't care about that. I think just the pace of the work meant that everybody was just trying to stay alive, really, and trying to meet an unmeetable need, and working faster and faster and faster and faster. And I think, unfortunately, currently in Australia, to make ends meet, a lot of GPs have to work that way. And it's a real shame because I think it takes away on not just from the quality of care we can provide, but the quality of life we can have as doctors, where we're actually thinking about what we're doing and we're taking time to, really celebrate when amazing things happen, as they frequently do, or to give time and space to the things we need to honour in our work. It's a very sacred job in a lot of ways. And we need space to do it well, I think. I was lucky in that at different points, not only did I have opportunities presented, but I had people that I loved and respected say, come on, I'll help you. I'll open this door for you. You know, I'm thinking back to when I was a medical educator, and James Brown, who, you know, is quite a senior figure in general practice training in this country and had been my boss for a long time. I had a lot of love and respect. But he said, come and join us and do some qualitative research. And, you know, I think you'd be really suited to it, and we'll help you and we'll teach you everything you need to know. And at the time, it was like, wow, he was spot on. This is really floating my boat. So it's more than just the opportunity. It's the people that tap you on the shoulder and tell you that they're going to give you a hand. And about the idea about trusting our instincts. And again, you know, I don't want to harp on gendered stuff too much, but I think a lot of women are taught to suppress their instincts about a lot of things, and probably men too, in terms of just how you're supposed to be in the world. And certainly medical culture has a lot of very strong hidden messages and hidden curriculum and things that we don't even realize is happening. But I think if I could talk to my younger self or my colleague, you know, I think encouraging people to trust their instincts. If your body is feeling something's not right, or if you find yourself repeating the same harmful patterns over and over again, or there's a problem in your life you can't get past, you know, there's something going on. You need to pay attention. Being able to be present and pay attention is the big core skill, isn't it? If we don't stop and take stock, we're never going to be able to put our attention in a particular place. You know, mindfulness practice changed my life. Again, something I kind of just fell into, but it's the foundation skill for everything else in my life. I can't make a decision if I'm not aware, paying attention, listening. How do I know what my instincts are if I'm not listening?
I was also really interested in empathy, not that word necessarily, because it hadn't really crossed my mind, but I was interested in the experience of that. And I saw a lot of, not to criticize, but appalling situations in healthcare as a medical student. So you go into the room, there's this terrified person in a bed, there's a great big steel chart, they pick it up, there's 15 white coats in the room, and the patient's looking around for kind eyes. And I used to lock eyes with those patients, and I said, I'm sorry, because it was heartless. It wasn't very humane. And so I got through that. Now I said, where's the empathy? Well, I know because of my movement history, I believe in flexibility and agility, like in my body, the way I move it and the way I think about it. Balance is important, strength is important, but I really emphasize flexibility and agility. And if you think about it, being a doctor, there's a certain inflexibility to that and a certain lack of agility, unless you're on the inventive curve of coming up with new treatments and surgeries and that kind of stuff. I think peers are essential if they can help you get out of the space that you're stuck in. If they just jump in with you, so if two people are stuck in quicksand, they're not going to help you. You know, I think, so you want someone who's not in the quicksand to help get you out, or if you're not in, to help get them out. If you're both in it, I think that's the problem. I've always picked my peers who see me as a total person. And I think for me, that's always been really, really important, because if I can't be my whole self, and anyway, another non-negotiable, I'm going to be squeezed and imprisoned into somebody else's expectations of me. It's a recipe for cracking. So if we can get the shame a little bit out of this and breathing space and say that it's okay to make a mistake. It's okay. Find support. If you don't understand something, find support. Let's make it not, let's applaud people who ask for help instead of shaming them for not asking for asking for help, and making it an easy space for people to have connections that are purely for peer support. It's very important to make sure I look after my energy. So when I'm interacting with people, I can portray it to them. And whether that comes out as music or writing or doing a therapy session with a client or just sharing a moment, like laughing at the same things, crying at the same things, Human beings absolutely require connective energy. It's the essence of our being on this planet, to connect with each other and have our communities and have each other. So I kind of just max out on that idea that energy it's here. There's no question, that there's air and you can feel it. And to make sure I look after my energy. So when I'm interacting with people, I can portray it to them. And whether that comes out as music or writing or doing a therapy session with a client or just sharing a moment, like laughing at the same things, crying at the same things. I said, well, I'm a doctor. I live in, Canada. And no, no, no. Who are you? It blew my mind because I didn't know. And that's when I realized, wait a minute, if I don't know who I am, how can I be optimally myself in my career, but in my relationships with my children, if that was going to happen, and it did, luckily, and grandchildren as well. Who am I? And I think what happens when you get into medicine, it's such a comprehensive experience. It can become your identity. And if medicine is essentially your identity, you need to find some other ways to identify yourself. And that could be a hobby, it could be a new relationship, could be taking vacation somewhere that you've never been before. I'm a doctor, I live in, Canada, and no, no, no. Who are you? It blew my mind because I didn't know. And that's when I realized, wait a minute, if I don't know who I am, how can I be optimally myself in my career, but in my relationships with my children, if that was going to happen, and it did, luckily, and grandchildren as well. Who am I? And I think what happens when you get into medicine, it's such a comprehensive experience. It can become your identity. And if medicine is essentially your identity, you need to find some other ways to identify yourself. And that could be a hobby, it could be a new relationship, could be taking vacation somewhere that you've never been before. So being self-aware, having self-empathy, answering that question, who am I? What is my life about? And I think this is the value of taking a vacation outside of your life, because you can see yourself outside of it instead of being in it. And often people come back from that space and say, oh, I can make some changes here. Physicians have to learn how to be okay with being vulnerable.
A decade ago, I reckon, so I would have been mid-40s, I decided to start seeing a psychologist. And interestingly, I didn't think there was anything wrong. So it wasn't fixing a problem. It was more that I'd got into my head that, we put our car in for a service every, whatever it is, year or two. We see the GP every year or two. We get our teeth checked every year or two. And yet the most important organ of our body, we just fly by the seat of our pants. We don't even bother to get that checked or a tune up, or are we, is it going okay? So I just thought, for sort of proactive, preventative type health reasons, I would see a psychologist. And I found that extremely useful. Again, there was no particular issue at the time. As it happened, that turned out to be, and we can talk about this later on, it turned out to be a masterstroke, because then stuff did happen, and we can come back to that. But my psychologist, because I'd been proactive, had a baseline on my normal sort of self and function, which I think was probably very useful. Finding the balance is key. When I did tell this story, state meeting in urology, people came up to me, and it's a bit like men with prostate cancer. Once they get a diagnosis, suddenly all their mates, they realize they've had prostate cancer and they can start talking about it. I see that all the time. And similarly, other surgeons came up to me after the talk and said, oh, yeah, same. Yep, me too, that sort of stuff. So I know from that, and also you don't have to be a genius. I mean, you just look at the statistics. We know that there's high rates of anxiety, depression, substance abuse, and all the other negative things that goes on, not just in surgery, but amongst doctors generally. It's a demanding job.
It's a very demanding job. I think I have so much more compassion for doctors now than I had 13 years ago when I began this journey. You said something, I think, very important, Jeremy, that at some point during this process when you had anxiety, you said to yourself, it's time for me to have some care now?
Empathy is really the greatest human strength. It's how you use it is what's important. Like any quality or asset or trait that's positive, there could be a dark side to it as well, a shadow side. And if we over-index in one way or another, we're probably going to get it wrong. So it's about finding that balance. We talked a bit before about emotional empathy versus cognitive empathy. For me, that's something that makes sense. As a practitioner, I think empathy is absolutely critical, but you've got to figure out what's going to work for you in terms of maintaining your humanness as a practitioner, but also your energy and sustainability. Cognitive empathy is something that seems to work for me. So that's something I want to mention. Also, that, and this might sound a bit Orwellian, but vulnerability is strength. It's not weakness to demonstrate your vulnerability, and again, within context, in a trusted environment with the right people, where it's going to be useful, not as a woe is me, I'm a victim mentality at all, in a manner of sharing, yeah, I'm human, and sometimes I struggle and sometimes I need help. And as a helper or a carer, as we are in medicine, that's okay too.
When you're heavily stressed, you revert to a survival mode, and it's impossible in a lot of those settings to use a lot of those skills when you're so distressed. And even at that like baseline of distress, it's hard to do. You're just pushing through and surviving with that little voice going, "You're going to get on well again. This is not going well." You know that might happen, and it's just constantly telling you that. And there's this shame, I think, within people who do fall into that and who do sort of fail to adhere to a preferred narrative. And I experienced that myself, getting back early on was very difficult at the very start of my, in my intern year in particular, and starting to do work around advocating for the mental health of doctors. I was lauded for that and given, Registrar of the Year. And then when the shit hits the fan, so to speak, you really see who's supportive and who's not. I mean, it's easy to support someone when they're well and to say, we're championing supporting mental illness and we're not stigmatizing, there's no discrimination, all of that, until the challenge comes. Because once you become difficult, that's when the actual discrimination comes out. And that is particularly bad, I think, for people who don't stick to that hero's journey or that ideal of it anyway.
Or even perhaps people who take too long to get through the hero's journey.
Absolutely.
There's too much complexity for too long. If you have, one incident and you get it together and you get the skills and you come back better, we like that as humans.
Yeah.
We like that simple, kind of straightforward.
Yeah, it's neat.
I want to go back a little bit to you talking about the connection with your clinical team all the time, not just when the shit's hitting the fan, but just all the time. Generally speaking, I just want to kind of amplify that for a minute and remind us both, and anyone who's listening probably, that I think there's such power in this. And when you look at workplace wellbeing, traditionally organizations, not just in health, have had EAP and sort of crisis response management, and that's been the focus. I think now we have evolved a little bit to thinking about psychosocial wellbeing at work all of the time. I think we've still got a lot of work to do, but at least we're talking about that language now, and we're talking about, good work is good for wellbeing. People who have work that helps them feel like they're contributing, that gives meaning to their life, that helps them feel like they're valued, is really great for our mental health as a general statement. Long-term unemployment is better for us, for our mental health, than a toxic work environment or an unsupported work environment. So, I think the research is really clear about that, but we seem to be very slow about activating it. And I think I mentioned to you before that I like the phrase of having some redundancy in the system. So, I'm thinking about we want the capacity to have heroes' journeys individually some of the time if it's about skill building and increasing our competence. We also need this systemic response and it's much more complex because there's more moving parts. Where's your thinking at just now about things that systems can do, or things that you've seen leaders do that have made a difference in our systems?
Yeah, it's a good question. I think it ties into what you said before about one of the key problems is when people take too long to get better, because it interrupts those systems. You know, we're caught between so many moving parts in medicine, particularly in the training pipeline, where we've got more doctors graduating than ever. And importantly, we don't have enough doctors, but we haven't seen the same rise in training places. So they've got nowhere to go. And even those who are in training get stuck without the problems of taking time off due to their mental ill health. Trying to find places for rotations we have to do, things like that, makes it really tricky. This is massively compounded in the rural setting, where the access to those positions is just often not there, or if it is, it's very hard to put people in who then need to take time off. It delays everybody. And that's not the fault of the individual, but it often is framed as such. And so when a system is so rigid that it can't tolerate someone taking time off, and it doesn't even have to be mental illness. People get, pregnant with kids. People want to take long service leave. Like to force people into that rigidity and say, no, we can't do this, we can't fit those things in, is a massive structural problem. So when we talk about redundancy, I think part of that is, saying, let's get more doctors and get the capacity for people to fill holes when they come up. But it's also a responsibility of the colleges, I think, because when they have rigid training requirements, they are important. It's important for me, for example, to be doing child and adolescent psychiatry. That's a critical thing to understand, I think. But to have so few positions to be able to do it, and so few supervisors to be able to supervise it, it really makes any of those flexibilities difficult. And it's not just saying, oh, we'll change the structure of the training program. Like, okay, but we still need that experience, even if you make it a bit more flexible. So how do we get the supervisors? Well, you need more consultants. How do we get more consultants? We have to train them. You're stuck in this loop where there's no easy solution to it. And I think trying to break that open and see how do we adjust it? How do we fix it? I don't have the answer to, because I think I worry that no one does. And when that happens, all we do is we go into crisis mode when we're trying to support someone. And there's this phenomena, I think, where I think people in sort of middle management, who are often the ones making the decisions around how to support doctors when they do become unwell, get stuck in this adherence to policy and practice, and this is how we do it. I think what I learned when I was really, and multiple times, in the depths of suicidality was the thought that this will pass. It's a time thing. That will be okay. That's not saying it fixes it, but it gives me space to press pause and let things just be okay for a moment. When you're in that bad a space where you want to act on it, time can be critical.
That culture and that protection for others is beyond patient advocacy. It made me realize that we are not going to improve the quality of patient care until we improve the work environment or the quality of those that are giving the care, and expecting people just to be better and smile and be compassionate. And I mean, there are some patients that are, it's fair to say, there's some not nice people, and yet you have to, but their work environments are unreasonable related to the expectations or the outcomes that are being expected. And so I realized that the only way that will improve the quality of care is really helping those that are giving the care and making it better and easier. And so that's when I picked up that research and I went, right, I'm gonna run with this now, because the role of the care environment It's not the individual that needs to be better and go on more leadership, but the environment plays a significant role.
I think we share something here in our experience, and it's what struck me the first time I heard you speak about Kewen's death, that we might start from a place of patient advocacy or what it's like to be a carer or family of a patient. But we've both ended up with this more systemic view. These are conscious choices. We make a conscious choice, and you're role modeling that unbelievably well, Duncan. You made a conscious choice very early on to not name individuals, to not name organizations, to say, how can we be useful? How can we add something? How can we help this be better? I just think that's a very powerful example of active intentional choice, and it's really demonstrating the pro-social ideas.
And so that you can see in healthcare. Each person is doing what they need to do to survive, to persevere. And the problem is that the system absorbs those individual changes. And so you see it so often in leadership programs and other team and cultural development. You come back and go, oh, gee, well, Sharee's been on a course, clearly. And within 2 weeks, you've reverted to what you were doing before. The hype and the excitement of the team building exercise we went on a week later. Because the change is at the individual level. You are expected to change. And we're doing it with healthcare, we're doing it with the nurses and the doctors, going, you need to be more resilient. You need to be more kind, as opposed to what are the factors in the system that are suppressing or allowing the status quo to continue. And I think that's the biggest thing that I want to be focusing on, because it's not just about being kind. Of course we want to be kind, but kindness alone, you can be the kindest person in that type of environment, and it doesn't necessarily, it might have an impact on me, but it's not going to bring about that systemic change that is needed.
I identify myself as a patient advocate, and I do a lot of patient engagement consulting, and I write a lot about the patient experience. So I don't like speaking up. I've written before about being a reluctant advocate. I don't like conflict, but we have to, like, we don't have a choice, or your child is going to miss out on a lot. So I think I learned that from Aaron, but then I got breast cancer 9 years ago. It's 9 years since my diagnosis. And everyone was like, oh, you're going to be such a great advocate for yourself at point of care, because you've done this for Aaron and worked in the system all these years. And to be truthful, I was terrible. I was like a little mouse, I would describe myself. I was so terrified. I think I was scared of dying and, causing pain to my children. And like, it was all mixed up that way, that I didn't speak up for myself in any way, shape, or form during cancer care. So it's interesting that identities, I think that one, I lost that one. I totally shed it when I became a patient myself. And I've thought a lot about it. And I remember being in my oncologist's office and sitting on the treatment table and having the gown on. She had sent her resident in instead. So this young man came in to deal with me first before she came in at the very end. And he actually asked me, what do you do for a living? Which was weird, because nobody really asked me about myself. I was just a very generic breast cancer patient to them. It wasn't even a very exciting kind of cancer. I could tell that, is a dime a dozen. Breast cancer is so common. So anyway, she said, what do you do for a living? And I explained to him a little bit about my speaking and my writing. And he said to me, oh my gosh, he said, we need you to advocate. He said, that's what he said. You have to keep speaking up. And I could tell he was like struggling in some way, poor guy. And I'm like, me? You need me to speak up? He said to me, they'll listen to you more than they'll listen to us. Mm-hmm. And I actually thought that was like sad. I thought that was very, very sad. Obviously, he had maybe perhaps tried to speak up and he hadn't been seen or heard, but there I am sitting in my paper gown with no clothes on, and he felt as in the system that I had more power than he did. And so it just really speaks to the fact that neither patients nor clinicians are listened to or engaged at the higher levels, and that is frustrating in us because none of us feel seen or heard. And it also made me realize we have more in common than we have differences. Certainly he had similar struggles to I did. So there is a lot of pressure on patients, I think, to do that, to speak up. And what I wish is that we had safer spaces where we could speak up in a safe way, whether that is at point of care, in a clinic room, or it's around a boardroom table. And I think that's something that I push for very strongly, that it's the safe spaces that we need the professionals to help create those safe spaces for us to be able to speak up. And I worry sometimes health professionals are quite defensive because they feel so passionately about the work that they do. And if somebody speaks up that's contrary to something perhaps they have to say, that people don't like that very much. And it slows down the efficiency in the system as well, which I know in Canada, very much our system's built on efficiency, getting as many patients through as you possibly can. But I think having an advocate would actually help everybody involved. It would make the professional's job easier too. But it's a funny thing. There's a lot of power that's involved with healthcare, a lot. And it's funny that resident felt powerless, and he thought I had more power than he did, sitting in my paper gown with no clothes on underneath. Like, it's just like ludicrous. I don't know who holds the power. Up in the ivory tower somewhere, I think. The acceptance part, I think we cause a lot of our own suffering because things are one way, but we wish they were another way, and the suffering is in between. So the acceptance of the way things are, I think, is very, very helpful. And ACT talks a lot about feelings and the fact that all feelings are okay. Like it's very human to have feelings. That's the human condition, and how we often try to push away the harder feelings. And they have this image of the beach ball. We're always trying to push the beach ball down all the time, and it always pops back up in some way. So, just thinking about feelings, and I'm a very feeling-y person. That's like, I wave my arms and hands around like I'm very dramatic and stuff. But there are certain feelings I struggle with, like anger and sadness are difficult feelings for me. But there's this great quote from a poet who actually recently died of cancer just last year, Andrea Gibson, her name is. She's a spoken word poet from the States. And there's a great film about her on Netflix. But she says, whatever you are feeling, name it love, she says. And I think about that a lot. And so, as opposed to judging how we're feeling at the time when things go hard, if we could just think about it as being love, I don't know, there's just something very calming about it to me. So I love that. Whenever you're feeling, name it love. Just staying in the moment and thinking about acceptance of all kinds of feelings has been quite helpful for me.
And then ended up doing medicine. Realistically, had no idea what that actually was. So I didn't have any personal experience with it. It was more of a concept. And I think that in some respects that was helpful in some ways, because I didn't have an expectation of what it looked like. And then eventually decided that I would do physician training, and my first experience with cancer actually was at the Austin Hospital as a resident, and I knew immediately that that's what I wanted to do, because what I loved about the work was that it was very much team-based. So, all the components, the allied health, the nursing staff, the other doctors, they all had an equal and important part. And I loved the fact that you would work together and support each other. It doesn't matter what challenges, where the challenges lie, whether it's at home or at work. I feel it's the same. I think probably the differences are that for your family, there's always the risk, I think, and I feel like this does happen particularly in the medical field, that because of the pressures of work and because of where you work, you sometimes can take for granted your family. And there's a real risk in that. So I think the difference is that your family is your family. And I've certainly been guilty of that myself, that sometimes you can sacrifice your family for your work. But at the end of the day, it is still work and your families, I think, should take priority, but we don't always do that, right? We think they'll always be there till they're not. So I think that's probably the only distinction I would make, but the skill sets, I think, are the same. That's my interpretation of it.
Can you name a couple of those skills? What do you think are important?
Oh, I think, one of the things for me is this concept of the being mindful of what's going on. And, I think for some people, they think, well, that's just when you do some relaxation and deep breathing. But what it is it's the gap between an experience and a response to it. So, and I think think about being aware of how your environment, the situation is making you feel, having the space to acknowledge that I'm feeling angry, scared, joyous, whatever, and then thinking about, okay, right, well, how am I going to react to that? I think, often the thing for me that's what probably most impactful was that until I spent some time looking at these things, it was pretty much brainstem stuff. And the problem with that is that sometimes when you do the brain stem stuff and it's something that is high stakes or high emotions, you can be down the track somewhere and then you think, how am I going to get out of this? I've gone too far, I've said too much, I've done too much, and now I'm going to have to backpedal a lot. Whereas having that capacity to just take a couple of seconds and think, nah, that's actually going to be really dumb saying that. I might do it a different way. I've actually found that really helpful personally because, again, I'm blaming my European genetics here that, we're often very emotional and reactive to stuff. And, particularly when you're in positions where you have to lead people, it's probably not the best way to operate most of the time. It just happens. It just comes out. That's one of the things that I've got out of the recalibrate stuff, or the process of doing it. I think for me, the other important components of it have been the concept of looking after yourself, and that's, you hear about that all the time. But about prioritizing what do you need to fill your bucket so that you can do the work. And I think probably in the past, again, coming from the background that I've got, the concept of self-sacrifice, in order to get through university and get your exams, that sort of stuff, where you do have to do a lot of delayed gratification. But when you get to the end, if you don't change up what you're doing, it starts to become deleterious to you. I think one of the important things about life, work in general, is having a really good idea of self. So what am I about? What are my values? What's important to me? Because I think if you're clear about that, then when you have to deal with important decisions, you can reference that and say, does this fit with what I envisage is important to me? I think that's something that's really important, because again, if we think about the medical profession, and it probably applies to many other careers, there's a strong sense of what a doctor looks like. What they dress like, what they sound like, and it's not true. And, to be honest with you, not everyone in the field is necessarily supportive or conscious of, some of these things that we're talking about. So, which is unfortunate, but it's a reality. So I think having someone that you can bounce ideas off or have a support network, I think is really important, because it'll help you make better informed decisions. Sit down and stay still for a minute and just think about what's going on and why you're feeling that way, because I feel like, as I sort of alluded to before, there's usually another option. You just have to find it. And and sometimes what you're thinking is happening is not what's happening, or you're catastrophizing something. So if you're feeling overwhelmed, just stop and breathe. And again, if you've got someone who you can bounce ideas off, I think that's also very helpful, because then they can either validate what you're experiencing, or they can say, that's not my perception. Have you thought about this? Because I feel like, I don't know, there's just a sense of urgency that you've got to, you have to make all these decisions in your career, and you've got to do it quickly, and you've got to do this and you've got to do that. And it's like, well, who says?
I just found general practice really hard going for a whole lot of reasons. High turnover, constant connecting with a new patient every several minutes was so taxing. And I've got great respect for people who can do it, but I struggled. And anesthetics is kind of polar opposites from that. One patient at a time, a small team around us, and very clear goal. And I think in reality, looking back, the general practice was a burnout for me very early in my career, and the change, was needed. But really, it took me further away from the opportunity to connect with patients. So to put that down and abandon a career that was in need of practitioners was something that took a little bit of effort, and was there was a bit of sadness around that, and perhaps some guilt. And in reality, while I was doing both, the part of my week that felt more uplifting, just to sort of lean into that wasn't as hard. It's like when I went into anesthetics, it was a relief to not need to connect with people every several minutes. And then in realizing, what that meant in terms of my opportunity to connect with people, was an eye-opening moment. So, it was an opportunity, I think, to start thinking how or what would I do differently. I don't think I had any idea what burnout was back then, but looking back, I think there were enough signs that that's what it was, that putting that down and going into something else, and you wondered if that was, a time of recalibration. And like I say, it may be that was actually a symptom that I needed to do some recalibrating. And that, I think, that depersonalizing, just seeing people as, a procession of people that I needed to get through the day, rather than, opportunity to, connect with people, was a sign of that as well. I think specifically junior doctors are often feeling like, if I work hard enough and make sure I've got all of the skills that go with my specialty at hand, then life will get easier, because I'll be okay. I'll be a qualified anaesthetist, and then, I won't worry anymore. But over time, I've come to realize that, it doesn't matter how good I get at my job, there'll always be something that will cause me stress or distress. And the additional skill set that I need is, how do I handle that stress, or wherever that distress is coming from? And it might not have anything to do with having, all this, top level skills of being a good anaesthetist.
The art and science of medicine and life.
So when we started the group that we had, there were 4 of us that committed to showing up every week, and it was just the 4 of us every Wednesday night for 2 years. And barely one of us missed a single week, just to build that safety and connection that would allow us to actually really start going deep on the stuff we were struggling with. I'm going to own it, because I've had more than a couple of instances from quite different parts of my life where people have said, how calm I seem, or how still I am. And I like being that way. And I think it comes from being able to, notice something happening, and, even my response or my reaction to it on the inside, but not feel like I need to do anything with it straight away. It's just central now for me. And I think that mindfulness is about, you know, the noticing of what's coming up on the inside, being able to actually physically feel my feelings. Some of the work I did in the men's circles was around, you know, being able to name and label feelings. Even in my professional practice, in the pointiest end of, you know, critical stuff going on, and you know, a lot of people in medical practice will recognize there are sometimes that the crisis is so severe it doesn't seem like there's even time to think. And I think that skill is applicable there. And you know, it amazed me one day when I caught myself in the middle of managing quite a serious crisis in an operating theatre, and you know, I caught myself just close my eyes for a second and take a deep breath, and then be able to turn around and go, right, what next? And when I noticed that I'd done it, and it's almost giving me shivers now thinking about it, you know, the next instance that there was a crisis, I made a decision to do that same thing. And, you know, it's not uncommon for people to turn and say, you know, you just seem so calm. And, you know, it's not like I am every minute, but, you know, it's a skill that can be practiced, and I don't think it's trained as part of anaesthetic training.
And it was another situation where, no, I wasn't allowed to go because of COVID. And I had to, I think from that moment, I realized that I had to get like assertive in, you know, navigating this system. And I mean, now that the time's passed, I can say it, but I had a friend who worked at the hospital where this doctor was. And I said, I have to be in that appointment, you know, like he can't go into that alone. And, you know, I guess strings were pulled, I don't know, but I was able to go to the appointment, and we were just told by this oncologist in a very sort of like brutal way. And to be honest, we ended up moving oncologists because the bedside manner just did not fit with what we needed, I guess. He basically said, you're incurable and inoperable, and the type of chemo that we're going to deliver, the FOLFIRINOX, that could be really fatal as well. And so when we got that news, we just realized that, well, they can't really help us. We might only have 9 weeks. Now I need to find the outliers. You know, I believe in the fact that, yes, there's statistics. I've got an economics degree. I respect numbers, but I also know that there's always outliers. So then I just, you know, decided that we had to take this matter into our own hands, so to speak, because the Western medical system wasn't giving us any hope at all. Maintain the hope that you can be the outlier. But I think the other thing too, Sharee, is Paul and I were realists as well. And so we got our affairs in order so then we could sort of live our best lives. And we fought the majority of the time that Paul had left. But I think that there's a time to fight, and there's a grace in knowing when to surrender, the outlier. But I think the other thing too, Sharee, is Paul and I were realists as well. And so we got our affairs in order so then we could sort of live our best lives. And we fought the majority of the time that Paul had left. But I think that there's a time to fight, and there's a grace in knowing when to surrender. What's it like for you having to deliver this terrible news to people? But I think from our experience, you know, being able to demonstrate that you've got empathy for that situation. And I guess it must also be a situation of trying to really understand what each individual and each individual family, what they need to deliver this terrible news to people. But I think from our experience, you know, being able to demonstrate that you've got empathy for that situation. And I guess it must also be a situation of trying to really understand what each individual and each individual family, what they need. I encourage health professionals probably to leading with empathy. That made an enormous difference to us, and the health professionals that we felt really supported by even though they couldn't offer us a cure, they were the kindest. They treated us with empathy, not with trying to tell us that everything was going to be okay. And sometimes the less said, the better, but just that knowledge that their heart is sort of with you is enough.
You came to uni and you found all the heads in the jars, which I just can't imagine, VJ. Now I'm saying, thank goodness I'm a psychologist. So that was a recalibration already, that you were recalibrating from thinking about being a vet. But this, I think you said a vocation, this core sense of purpose that I want to be able to affect change in the world. Do you feel like you've been able to? Has being a doctor facilitated that desire?
Yeah, I do. I think that the opportunities have come, and I think it's important to be clear. It wasn't that I thought I was the person to save the world. It was more a sense of a need to serve. That was what your purpose was, is to serve. And I think that that's what medicine provided me with the opportunity to do. With an individual who's in front of you, to serve her and look after her and care for her and provide her with the medical care that she required, to then have the opportunity, because of that position and the connections that came with it, to serve in organisations or in roles. And it turned out that those roles then became leadership roles. And not for any particular reason. Maybe there are a set of skills that are related to being a leader. Maybe it is a personality thing. Maybe it's a desire to lead. But those opportunities certainly came up repeatedly. And I took those opportunities. I found them interesting. I found them challenging. I enjoyed that role. Sometimes you don't enjoy it because it can be enormously stressful being in a leadership role, and that sort of leadership role that a doctor takes in the nature of their relationship with a patient as well can be enormously stressful, because you can have self-doubt. You can wonder whether you actually know more than your colleagues, or whether that person might be better off being looked after by someone else. So that's something that one has to have a degree of humility, but also learn not to be humble to the point where you're sort of incapable of doing anything.
Immobilized.
Yeah, that's right. And so, but I enjoyed that opportunity to then, and the other thing about, I think, leadership roles is that you've got a seat at the table as well. So you actually have the opportunity to find out how systems work, how government works, to interact with the change makers and the decision makers. And that becomes really fascinating. And you get a better understanding, when we circle back to what we were talking about before, about the problems with the system, is that you actually start to understand why some of those problems are impossible. Or far more challenging than they appear when we're sitting in the armchair being critical about it. Actually, it's not that easy.
You're really in the arena, aren't you, as Brene Brown would say.
I think being a clinical manager is really lonely when you are protecting your staff from the challenges that exist that are coming from the top down, and also knowing the complex interactions or the complex personal things that are occurring for your staff, and holding that in a professional way. It does make it very lonely at times. And that's something that I've had to learn to deal with. And that's part of the reason why I run or get in the garden or have those positive outlets, because you can't hold all of that yourself. Like, it's too much. And I don't think anyone expects you to hold all of those emotional things. You have to hold it, but you have to know when to step out of the door and put that down, to be able to walk into the door with your family, your kids, and be present. That is a hard thing to learn as a clinical manager. And that was what triggered me to go, it's time for another change. I know that I, my own self, probably am not being as effectual as I'd like to be, and not that I'd lost passion. My passion is very much there, but I needed to change again. I needed to think about how I could do something different in a different way, but still provide the level of care or service or support to other organisations. That was not an easy decision to make, to step out of my whole life had been really tailored, working in public health service. I thought I would live and then die within a hospital. It was a real shift. It was a complex shift. Your ego, your sense of self is attached to that. And so to step outside of that was a big change. And people said, oh, you're so brave to step outside and, you know, to lose all the benefits of working in government for such a long period of time. But for me, I felt I couldn't stay. I felt like they were brave to stay. I really needed, for me, I felt a level of abandonment, actually, leaving my people where I knew that there were, as there is everywhere, challenges with staffing. So there are all these amazing things that I think is important to know, that yes, we are nurses, yes, we are doctors, but all of these skills and assets and attributes that we have can be placed in lots of different areas, even random areas like adventure racing. So the ability to transition between different careers, different opportunities, are incredible, because healthcare provides you, and being a clinician provides you with all these attributes that sometimes you don't think are transferable. Amazing things that I think is important to know, that yes, we are nurses, yes, we are doctors, but all of these skills and assets and attributes that we have can be placed in lots of different areas, even random areas like adventure racing. So the ability to transition between different careers, different opportunities, are incredible, because healthcare provides you, and being a clinician provides you with all these attributes that sometimes you don't think are transferable.
I mentioned my kind of drop off at fellowship, and I took a couple of years of opportunity to do different things, a lot of navel gazing and probably soul searching. We have our finite locus of control, and I think being able to realize that what is it? I think Pema Chodron says this really best, you are the sky, everything else is just the weather. I love that. And, I think, and again, maybe my yoga practice kind of helped me think a little bit more about surrender, because that's certainly, what's the most difficult pose? It's Shavasana, and that's a pose of surrender. And actually, that's the hardest one. The work of Professor Amy Edmondson on this topic, kind of just thinking about failure and what it means in the different types. So, I think in medicine, we think a lot about, the simple failures, which are the kind of never events, the kind of wrong site surgery. And, we should have good, robust clinical governance systems to support and, make those very, very, zero is what we aim for. Whereas a lot of error that we see in medicine, or failure, whatever, for, in inverted commas, is complex and pervasive, and it involves humans and systems and we talk about the Swiss cheese when all of those holes line up. But the bit that we don't perhaps talk about enough is this concept of intelligent failure. And we can transplant hearts because of intelligent failure, all the innovation, the growth, that's the bit where we've got to remember that in healthcare, that's actually really matters too. So that should give us some courage to translate into our lives in terms of how we kind of go forward. And I do think there's pockets of, really excellent achievements. I still think, how we can take some of those examples very much. How do we, take the example, pilot, iterate, and scale in our own environment, knowing that, without having to reinvent the wheel every time. And there are, so many of those. But then I keep coming then back again, full circle, to individuals. And I think the work that you do, I love this word agentic, because you are giving agency to us and you're helping us to develop those core, intra and interpersonal skills. Because the system is made up of people, and, we make the system. It takes we'll take a critical number, and, kind of elevation of voice and maybe some other skills. What I struggle with is maintaining momentum. And I think many of us who have been doing this for some time do. Sometimes if you particularly have some individuals who are doing great work and we're not really thought about succession planning, it could just take them to have to leave or step back, or, change of, other leadership or funding, and things fall apart. And it's probably the first thing that goes. And I think that's the kind of concern. It's still maybe an added extra, not really something that we do as core business.
Thank you for listening. I look forward to sharing our next conversation with you next week. And in the meantime, may you be well. The content in this podcast is not intended to constitute or be a substitute for professional medical or psychological advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified healthcare professional. This podcast represents the views of the hosts and guests and do not necessarily reflect those of any entity we work with or for.